Hi, Jordan.
Morning, sir. How are you?
Hi, how are you? Good afternoon here.
Yeah, 2 o'clock your time.
Yeah, 2 o'clock here. Yeah,
Good. It's early here.
it is. So you're ready for a busy weekend?
Yeah, we're leaving Monday for vacation, so we're getting a lot of stuff done this weekend.
Awesome. That's
Yeah.
great plans.
Yes.
So how is business going?
It's good. Yeah, it's good. It's kind of stabilized and just trying to get caught up and, you know, keep things humming along. But it got a little overwhelming at first in a good way, and now it's smoother sailing, I think. Yeah.
Awesome.
Yeah.
Yeah, of course, a lot of guys in the United States will still be
I know.
sleeping, but we've got a lot of questions in advance
Oh,
on
good.
YouTube and in the Facebook group. So maybe
Perfect.
start with those.
Yeah.
Someone asked in the Facebook group, can we discuss hair loss when not genetically predisposed and acne while on TRT? So maybe let's start out with the hair loss. Is that something we have to fear even if we are not genetically predisposed?
Predisposed. I don't know about fear. Fear is not a good word for it, I guess. I mean, everybody's different when it comes to what they think about their hair. I'm kind of in that transition point right now where I'm starting to notice, a little bit of thinning and stuff. But I think the hard part is, again, a lot of guys want to blame it on testosterone. Well, you can't know that because you don't know what would have happened to your hair had you not been on testosterone. You can speculate, oh, I feel like it's sped up or I'm shedding more, but you don't know for sure. It just doesn't happen to everybody on testosterone. It's just like in real life when you're not on testosterone, it seems to be, I hate the word genetically predisposed, but it's like it's something that's either going to happen or it's not. But there's also other factors in people's lives that can accelerate hair loss, stress being one of the biggest ones, thyroid issues, things like that. So I don't like the idea of fearing hair loss, first of all, because that's not going to hurt you. Um, I do understand though the issue. I mean, I've thought about it before already. Like, I'm not going to start taking finasteride or anything like that personally. But it does start to bother you when you start aging and looking different than you used to. You have a full head of hair your whole life, and then all of a sudden it changes, and it is a little different to get used to. But I've got some patients that are concerned about their hair loss, and they'll ask me about taking topical things, minoxidil or combo minoxidil finasteride. Again, I'm not going to sit here and lecture guys on what's best for them when it comes to that. I think risk and reward, you have to balance that, and everybody has a different tolerance level for that. So if you're truly concerned, I mean, if you've got a beautiful set of locks on you and you're like, I don't want to lose a single hair, so I'm going to take minoxidil finasteride topically, go for it. Be my guest. If you start having negative, side effects, I hate the word side effects, negative effects, you feel worse, you start losing erections, you lose your libido, any of these little things, may be worthwhile to think about not taking that stuff and just see how you do. I mean, I know the big answer in the group is shave your head and grow a beard, right? Like, and that is, we can all, look like Dave Lee, and I'll probably do that, honestly. Like, if I end up truly losing it to that point. But again, I don't think it's something anybody should fear. I don't think there's a way to prove TRT caused it or not. I don't even know that I'm convinced that the topicals can truly, they're not going to regrow it, most likely, from what I've talked to other people about who've been taking it. Yes. And I mean, they might seem to slow it down. And so then you're like, okay, I'm buying some time. Again, at what cost? If you feel fine, maybe fine. So just evaluate that for yourself.
Yeah. And what about the acne? Is it your experience that you see a lot of men getting acne in the beginning of their TRT?
Early on, I mean, I think, I noticed the first even couple of weeks when I started TRT, my skin was oilier. You could wipe your forehead and just be grease. But then after about 4 to 6 weeks, it kind of stabilized for me. I don't have a lot of issues with acne as far as percentage of my patients, it seems like, or at least I don't hear about it. The ones that are truly bothered by it or having some really big, like cystic acne type problems, I will hear about. And those guys, more times than not, we're able to, they're usually on injections. and we're usually able to switch the carrier oil around to clear up their skin quite a bit. I've had a lot of guys doing commercial cottonseed oil, sesame oil preparations, and we get them on either grapeseed or MCT oil. I prefer MCT oil if we can get it for them. Just seems to be a lot cleaner. And lo and behold, 6 weeks go by and their skin, you know, they message me like, "Hey doc, my skin's clearing up." I'm like, "Oh yeah," because you're not injecting, you know, everybody's different with how their body responds to those things. Well, you're injecting seed oils into your body, you're probably going to stimulate some inflammatory response if the body like that. So now when it comes to like hormonal acne, quote unquote, man, that's a trickier one, because some guys, it seems like no matter what, you give them a little testosterone, whether it's cream or injections, they just get acne. And I'm not I'm not going to tell them, no, you don't take Accutane or don't do this or that. I want them to be informed with the risks of that. I mean, we know that again, it's the same thing with taking something for your hair. You have to be willing to accept a trade-off usually. And I think a lot of guys just aren't, people in general don't like that. They want everything to work the way they want it to, and it just doesn't work like that.
Yeah.
You know, there just seems to be trade-offs, and opportunity cost essentially. But yeah, for acne, I would always tell guys, you know, we see these posts in the group a lot. The first thing to look at is if you're on injections, what kind of oil are you using, what frequency of your dosing, all that. If you're on cream, a lot of guys just, you know, we'll check a level and their free testosterone's 50 or higher. It's like, okay, we may want to, I know you feel good, but may want to drop your dose down just a little. You may still feel fine, but it may clear up the acne a little bit. And then also with acne, as you know, they've got to look at every other thing they're putting in their body. They've got to look at their diet. They've got to look at their metabolic health. All those things apply. Other medicines they may be taking. So it's not just a one-trick pony when it comes to acne. I know a lot of people want to blame it on the hormone, but it's not always that straightforward. Obviously, when you start a new hormone and you get acne, it's like pretty obvious, okay, that probably caused it. But you don't know if it's the hormone that caused it or something else in the preparation, especially with injections. So just be sure and test different variables.
Yeah, exactly. I see in our group a lot of people ask me about Accutane. A lot of them are afraid about it. They compare it to the side effects from finasteride, but that's not really the case. There's, I've prescribed isotretinoin because that's the generic name. The molecule Accutane is brand name. Here it's even called raw Accutane. If you microdose it 10-20 milligrams a day, the side effects aren't that bad at all, except maybe for some dry lips. But next to that, there's almost close to nothing really.
Yeah. And everybody tolerates it different. You know, I've had some people, they have just a little bit of dry, and other people look like they're losing fish scales off their face. You know, but that's usually probably a dose response relationship there.
It's very dose dependent. That. I had someone asking on YouTube under the notice about this live stream. Hi, Dr. Grant. TRT cream is becoming increasingly more accepted. I would like to hear everything you know about the cream. So that's probably a lot. What percentage of men do well on compounded cream? Maybe let's start with that.
I mean, I don't know in general. All I can tell you is my own experience as far as who does well. I will say the majority of men that I get on cream stay on cream. I have a lot of guys that switch from injections to cream, and I would say the majority, so greater than 50%, stick with the cream. Some go back to injections just because either it didn't absorb well for them. Honestly, that's rare. I would say it's more of a convenience factor. Some guys just prefer not having to apply something every day or twice a day, and that's fine. But as far as the efficacy, if you source it properly, know your compounding pharmacy, trust their product, know that you've had good experience with it, consistently over time, make sure it's the right base. And sometimes you got to play with that stuff, but it works really well for most people. And I can just tell you anecdotally speaking and personally that it was a game changer for me, as far as how I felt, and the mental clarity side of things was what really changed. And, Eric Serrano mentioned that we were at Silverback Summit back in November with Allie, and even he had mentioned on stage up there that his patients on cream just they just feel better mentally. They just have less brain fog. And I can 100% attest to that. Is that true across the board? No. But I don't think this fear people have that, oh, it's topical, it must not be as good. They think that just because you're injecting something in the body that it makes it better. That may be true as far as just getting a blood level. But all things being equal, if you absorb cream well, it's really just personal preference and or efficacy. You know, some guys just feel better with the cream. So I can't tell you everything about cream as far as like how are they sourcing it and what are they doing as far as truly making it. I haven't watched a compounding pharmacy put it together. I just know that they've come up with ways to do it that seem to absorb it pretty remarkably well. Actually, I've been pretty impressed with it. And it's the same for females, right? Like they've got all these different bases now, certain bases that go better like on the vaginal mucosa that wouldn't go well on just the normal skin. And then other bases that seem to go anywhere you can do fine. And so it really is trial and error. I usually use a Trevis base, but also HRT base or HRT heavy base. I like a lot. Some guys prefer Versa. I kind of go with a Trevis first off. And then if that doesn't seem to work well, or if they get a skin rash or something like that, we'll switch to HRT base. My wife for females uses what's called the Elage base. It's more of a, it's a thinner, it's not really even as cream. It's almost like a lotion. But yeah, cream in general, it's becoming more accepted because it works well. I saw a TRT clinic or an owner of a TRT clinic the other day on Instagram posting something about injections and these are the best way to do TRT. And it's like that's like saying vanilla is the best flavor of ice cream. It just doesn't, it's subjective. We'll say it's objective in a way, but also subjective for the individual. Everybody's different. So I think I tell my guys, you kind of, if you're on the fence about it, try it. If you can get it, if you trust your provider, they know where to source it. I think you owe it to yourself. If you're not feeling great, you kind of owe it to yourself to at least try it, like mark it off the list if it doesn't work for you. But that's what I tell my guys. New patients that come to me, if they've never taken testosterone, I try to kind of steer them to cream first because a lot of them don't want to mess with learning injections. And I'm like, if the cream works well for you, you'll probably stay with it. If it doesn't, again, that's good because we know, hey, it just didn't work well for you. Let's mark it off the list and let's play with the injection side of things. So, but anyway, I hope that's kind of a vague answer as far as tell me everything you know about cream. But in general, I will say, and as far as a few, and I know there's controversial people disagree with this, but I do not see the elevations in hemoglobin hematocrit on cream like we do on injections. It just doesn't tend to happen. Do I think anything of that? Not really. I think it's interesting. I don't tell guys to donate, even if they're on injections, if they're running high per se. So it's not like I think hematocrit is a problem, but I do find it fascinating that we're not seeing, those issues with guys on, sorry, I think it broke up for a minute. I think it's fascinating we're not seeing the hematocrit issues on the cream. And it makes me think there's something in the injectable other than the testosterone that's causing that, whether it's the injection of the oil or preservative, something that stimulates that red blood cell production more than a cream would. So it's interesting.
Yeah. Another question, he said, are certain compounding pharmacies more reliable than others, or are they all fairly competent?
Well, it's all over the board, man. Like it's so frustrating. You would think, oh, I'll just go to my local compounder and get it made and and that's not how it works. They've got to, just like anywhere else, they have to take seriously what they do, enjoy what they do it right, do it well. And not all of them do. And I had issues with guys who've used small compounders before and like their first set of labs are great. And then a couple months go by and they start, they're like, doc, I don't feel good this month. I feel like I'm not on my testosterone anymore. I'm like, well, let's check some blood work. And we check it and their levels are 300-400. And I'm like, did you put your cream on? Did you do everything the same? Yep, sure did. And I've had that happen enough. So I'll switch them to like MedQuest, which is a mega compounding pharmacy out of Utah. And then we never have that issue again. So it is kind of interesting. And so I tend to go with MedQuest unless somebody has a preference and they just want to try local, because I just never know, and I'm like, if you're going to try, do it with the best possible route that you can with the most reputable pharmacy, at least at first. Once they kind of dial in on their cream, if they want to try a smaller compounder to compare, go for it. But a lot of them are pretty happy with the the bigger brand, and it's the same price. Honestly, they're very affordable either way. So, but yeah, they're all over the map. I can't remember. I think it was 4 or 5 years ago, maybe. It may have been Keith Nichols that talked about a study done, I think, on compounders in Canada, and they were testing different amounts of testosterone. I think it was testosterone in cream, and it was all over the map. As far, some were like 0%. I mean, it's just, how does that? This just means they didn't actually get it in solution or whatever. Like, it just completely crashed. And that's the other thing. You don't want. I've noticed some compounding pharmacies will say they can do up to a 30% strength cream. I would probably stick with 20 or less. I think you're playing with fire, getting up into that 30 range or more, where it may just crash and you don't get anything out of it. So,
how long should one wait before adjusting the protocol with cream? Because the results are more rapid than with injections.
They're quicker. I usually tell guys, honestly, at first, when you're first starting testosterone, I still like them to give. I check blood work at a month to make sure they're not wasting their money on it. If their numbers are quote unquote good at that 4-week mark, I usually tell them, hey, either ride it out where you're at, or if you want to add a click, do that. And then once they do that, once they start adjusting, I think usually with a couple, 2 to 3 weeks, they can kind of tell on the cream what's happening. In fact, some guys know within a day or two. Honestly, it's that potent, because there's no ester attached, right? They're not waiting for this whole time release. And I know theoretically, once your blood levels are a certain amount with injections, you should still notice those differences, but it just doesn't seem to work like that. I mean, and everybody's different. Some guys swear they can feel even injections on one day, but in general, I do tend to say, don't spend as much time waiting it out on the cream as I would somebody on injections. 3 to 4 weeks on cream versus 6 to 8 weeks on an injection protocol, let's just say.
Yeah, the typical worry people also have is it possible for DHT to get too high with creams?
Again, we're back into that whole, how do you test that, right? Because DHT serum levels are going to be the same issue as you have with estradiol levels, where are you getting an accurate reflection of overall DHT production? Or at the tissue level, you don't know. You don't know in what tissue is it high and what tissue is it low. Getting just a snapshot of serum levels doesn't actually tell you what's going on at the tissue level. So that's where I get a little, it's like, I hear all this stuff about, oh yeah, cream converts more to DHT. I haven't ever looked into that because I don't care about the serum and DHT levels. So I'm not really going to go off that. I don't know if anybody's ever done a study on that, looking at that. I think it doesn't matter. Here's the thing. Whatever the story is, people always do this. They confuse their effects with the story underneath. So if you feel worse when you go up in your dose on cream, it doesn't matter if that feeling worse was from DHT or increased free testosterone or whatever. Drop your dose back down to see if you can feel better. This idea that we need to start, quote unquote, balancing these other hormones. The body is the best at balancing. It knows what it's doing. That's how it's made, especially when we're talking about conversion processes that we can't even really measure, that we just think are going on. And so it's like, just be careful with getting into those rabbit trails of thought with worried about DHT or worried about estradiol, or that it's like big picture, dose response, adjust based on symptoms. Like, stay out of the weeds with constantly worried about the lab stuff. That's my own personal opinion on that. So
I see Dave Lee and Ali Gilbert are getting into the chat. So hi guys, hi Dave, hi Ali. So yeah, let's see what they are writing there. You pull it off bald head and a beard, Jordan. Yeah.
Let's see. I think he asked something about Dave asked something up above there about varicocele.
Yeah.
Let me let's just
Does Jordan recommend varicocele embolization before looking at laparoscopic varicolectomy?
Oh man, yeah. And I never did varicocele stuff as a urologist myself because I hate it. And because if you don't do it the right way, they'll often come back. And I would honestly say neither of those are great options. Laparoscopic probably might be better than embolization. Embolizations often fail. They work temporarily. And kind of the same thing with the laparoscopic varicocelectomy. They're only clipping the main gonadal vein. You're not getting downstream, upstream, actually closer to the testicle, where there's multiple veins coming off, and they all conglomerate into one. But I would say the number one method for truly fixing a varicocele would be a microscopic varicocelectomy. And so you get a surgeon that's good on a microscope, and they do like a subinguinal incision, kind of like if you were having an inguinal hernia surgery, and they'll tie off each individual vein coming, the pampiniform plexus veins coming off the testis. And that seems to be best results with least likelihood of coming back with a hydrocele or something like that. Because if you just take everything, you're getting the lymphatics in there too. You can't see them. Well, then that's going to affect the drainage. And so I think you're much better off. Now, if a guy just wants to try it, embolization, obviously safer. You're not going under probably even a general anesthetic for that. So the risk is going to be a little lower. It just may not work. And then people are mad because they're like, well, it failed. But as long as going in, hey, it may not work forever, I think that's fine. And then I think, let's see, what else did Dave say? What does Jordan personally think leads to prostate cancer in the standard? Oh my gosh, man, I'd be speculating honestly on that. We really have no way to prove that because again, look at every variable in every individual's life, every single person. It's different. Every one of us is unique. The way we live our lives is pretty unique, even though we're all exposed to the similar stuff, but in different ratios. It's impossible to study that. This is where epidemiology and things like that come in handy, but they never prove cause and effect. You just get a lot of different speculations on, well, it could be this, it could be that. Let's look at these trends. Let's look at these correlations. I don't know the answer. I will just say what I always tell guys when they ask me, like, what can I do to improve my prostate health or lessen my chances of getting prostate cancer? I'm like, the same thing you do to reduce your risk of getting any cancer is be as healthy as you can be. That's it. And that includes looking at the other things in your life that, crappy processed foods, poisons, heavy metals exposure. The list is a mile long, and that may even still not reduce your chances of getting prostate cancer. Maybe something else unforeseen that happens that you don't even know you're being exposed to. But I definitely don't think it's hormonal. Obviously, the majority of guys that get prostate cancer already have low testosterone, right? Mm-hmm. But yeah, I wish I knew the answer to that one, man. I don't even fully understand cancer anymore. The more I research and look into that stuff, it's just a very interesting topic. You start looking at the differences and even how a pathologist will define what they think is cancer. And there's massive disagreement, even looking at a slide, and you can start going, how many people are getting treated for cancers when they don't actually have cancer? You don't know just from always looking at a cell line under a microscope that it's truly the C word, So, you got to go with your gut on a lot of that stuff, but I don't know the direct cause.
Dave says, I found that guys who are more prone to side effects on TRT, overweight, alcohol consumption, etc., receive less side effects when starting TRT compared to injections. Have you seen this?
Oh, does he mean cream when starting cream? Yeah. Yes. I totally agree. And I speculate that, again, same reason a lot of guys get acne, same reason for the hemoglobin hematocrit issues. You're injecting foreign material, you're injecting seed oils, you're injecting preservatives into the body. If you're already a more fragile person, metabolically speaking, or health speaking, I think the ability to process that stuff goes down. And so you can't just truly be focused on the one variable you need to be on, which is the testosterone and how is it affecting you. I had this conversation with a guy yesterday, almost identical, and he's young and healthy. So he's going to reap the most rewards from starting TRT because he's already optimizing everything in his life. Whereas, if I had a guy come to me that's 300 pounds, overweight, massive belly, drinks all the time, type 2 diabetic, starting testosterone on those guys often makes them just feel like crap. Really, not all of them. I'll be honest. I've been surprised sometimes how, they do feel better, but it depends on the person. But yes, in general, starting those guys on injections, I just tend to see more negatives. The one thing with cream I notice in my overweight guys is about the first 2 to 4 weeks, they get increased water retention, little edema in their ankles and feet, and they freak out. And I always tell them it'll go away after your body, stabilizes, and it does. I tell them, write it out another couple of weeks. Let me know if it doesn't, obviously. But almost every case, it goes away. And same thing with blood pressure spikes and things like that. But again, they're overweight. They need to work on all that stuff. And that's why guys in the group will ask these questions. about their hormones, and they're obviously not optimizing all the other parts of their life yet. So it's like you don't even need to be talking about what your testosterone. You can't prove it one way or the other if you're not already optimizing these other variables, because now you're dealing with multiple things at once, and so it's hard to say. So, but anyway, yeah, I agree, Dave. Cream seems to have less negatives when starting.
We skipped a question there from Edgar Rivera. Would injecting subq help with hematocrit?
I don't have guys do subq. I only have a few patients that I know of that are doing it, and so I can't tell you the trend as far as giving you a general average on a bell curve, like for subq versus IM. I know some clinics where they push more subq just for ease of use for their patients. I'll actually ask about that if they're seeing that on blood work or not. But my suspicion would be that it would be higher. But I don't know. It's actually an interesting question. But I'll just say this: subq, again, it's like everything else. It's fine if it works well for you. But a lot of guys will do subq, and number one, if you're not using the proper oils, it's just going to be a hassle. It's going to welt up under your skin. It's going to be miserable. If you get a good clean oil, grapeseed or MCT or something else, you still level for level, serum levels being equated. I tend to see just guys feel worse on subq than I am for whatever reason, and I can't explain that. I don't know if other than just the drug is being metabolized a bit differently because of it sitting under the skin there instead of it being in a depot in the muscle. But I don't know for sure.
Mm-hmm. I've been on TRT 100 milligrams for a week for a little over a year now. With TRT, if 100 is my dialed in dosage, does your body build a tolerance in time that requires dosage adjustments?
I don't know if I'd call it again, you're kind of lumping everything into just calling it a tolerance. A reduction in effect does not equal tolerance in the way a lot of people think, where they think, oh, my body's become more efficient at metabolizing testosterone, so I need to up the dose. Kind of like if you can start drinking more beers and feel the same. That's what a lot of people think. They built up a tolerance. I haven't seen it work that way with hormones per se, honestly. But other things in the life can change. Again, this goes back to what we were just talking about. Like a guy will say, I've been doing fine for a year on my testosterone, and then all of a sudden, the last 2 weeks, I'm feeling anxious. What do I need to do? And I'm like, why do you think that has anything to do with your testosterone? You didn't change it, and you've been fine. Like, look at other variables first. Then, if you feel like you need to adjust your testosterone, that's fine. But in general, I have not had to once we kind of do the first couple dose adjustments to play around with and find out where guys truly feel well. There's guys that have been on their same doses for years and still feel fine. So I would just still chalk that up to trial and error.
Can too much testosterone make you feel tired all day long, or does that sound like too little? My dose is 60 milligrams every other day, and I'm tired from the afternoon through the rest of the day.
Same answer. You don't know that it's from the testosterone. The only way you can test this is sort of change one variable at a time. Absolutely too high of testosterone in some guys makes you feel more lethargic. I've had that. Same with anabolics. Guys that take stuff, if you ever talk to them, they're tired all the time. They just kill it in the gym and then they can't even do anything else. But yeah, too high can definitely do it. That being said, though, make sure you only change one thing at a time. Tiredness in the afternoon could be a million things. Could be a big carb meal at lunch. It could be thyroid issues. I started taking NP thyroid just to help me feel better in the afternoons, like and just a little dose, And did I need it, quote unquote, based on my labs? No, but it helped. And so, do I think I had a thyroid deficiency? No. So it all goes back to how you think about taking these things. I'm starting to think of them more from a pragmatic, goal-based idea than just we're replacing a deficiency. Like, I think that's fine if you're replacing a deficiency, but people that don't have these deficiencies can still improve their lives and how they feel by taking testosterone, thyroid, and you just play with it to find out where you feel the best. So anyway, that's a tangent.
Yeah. Speaking of hematocrit and predominantly higher levels on injections, does that higher hematocrit level over time reach a plateau or begin to drop? Also, does aerobic activity decrease it?
I've never I've heard that with aerobic activity. I've never seen it studied. Obviously doing aerobic activity is good no matter what. So again, I tell people, like, doesn't matter, do it anyway, a little bit at least. But I've seen it typically plateau. And then, yeah, I have seen guys, but again, this is not every guy. So it's hit or miss because again, it's going to depend on how well hydrated are they on that one day. You have to control every single thing in a controlled study to truly answer this. So I can't give you an answer. I will just tell you that in general, it does reach a plateau. It doesn't keep going up forever. When I was on injections, sorry, my nose is itching. I'm not trying to pick my nose. When I was on injections, my hematocrit roughly stayed about 57, 58%. And that's just where it hung out. And it didn't keep climbing up. If I really hydrated well, I might go down to 54 or something like that. And then when I got on cream, my hematocrit within a couple of weeks went down to like low 50s. And that was just after a couple of weeks. But yeah, I don't know about the aerobic activity side of things helping the number per se, but it's going to help a lot of other things. So I don't neglect the cardio or aerobic activity, which I do. So I need to listen to that advice.
Jordan, does my doctor have to send in the prescription to MedQuest or do I have to order?
Yeah, in the United States, the doctor always has to send a prescription for testosterone. You can't just order testosterone from a pharmacy. You got to have it's controlled substance. So yeah, he can, but he could send it if you asked him to, or if he wanted to. I mean, it depends on the doctor. There's some doctors are contracted with certain pharmacies, especially if they're kind of reselling their meds. But if they're not reselling the meds and they're open to sending it to different pharmacies, then they could send it to MedQuest for you. Depends on it's a physician versus nurse practitioner. Some nurse practitioners, they're stricter in the United States, depending on the state they're in, if they can send a controlled substance across state lines or not, whereas a physician, usually not a big deal. So, but I'm not sure on your doctor per se, but anyway, yeah, you have to get them to send it for you.
Mm-hmm. How Ali asks, how do you define true ED and how do you determine what route to treat it? Is there an order of approaches you go through?
That's a tricky one, and like if I was still in urology, I'd probably give you some academic-y type answer. But even then, knowing in urology what we actually do day to day on the real side of things, it's still a lot of just, well, let's try this. If that doesn't work, let's try this. And if that doesn't work, let's try this. It's always a stepwise progression. Now, if something in somebody's history indicates there might be a structural problem, an anatomic problem. I mean, obviously, if a young guy that's been in a car wreck and has had a pelvic fracture or something, that's kind of obvious. But for these kind of random where it's like, doesn't make sense that they're having ED because they're healthy otherwise, I would still not try to go straight for like invasive procedures. Like penile Doppler even is not invasive, but it's embarrassing. And it doesn't always going to give, it's not going to always tell you what we should do. It's still going to be like, well, we need to improve blood flow, so here's some Cialis, right? Now, if they have venous leak or something like that, that might be useful to know. But I wouldn't jump to that first. That's going to be more a process of elimination. But if you go look at the textbook chapters on ED, my gosh, they're painful and long. A lot of guys, it's obviously psychogenic, or at least there's a component of that. You have to look at everything in their life. You have to look at their stress levels, their diet, their medication list is a huge one. A lot of these guys, even young guys nowadays, are on a freaking blood pressure pill and a statin. So, yeah. Okay, recipe for ED right there. Yeah. And they don't think twice about it. And I'm like, a 30-year-old, I'm like, why are you on a statin and 2 blood pressure? Well, my doctor told me I needed it. It's like, it just kills me, Yeah. So, we are being poisoned left and right, not just by the food and everything else, but doctors are poisoning people without, and it's, again, I don't besmirch people for taking a pill if they feel like they need it to mitigate some symptom they're having that they're worried about, but they need to have informed consent about that. They need to know, and the doctors have to tell them, hey, I'm going to put you on this blood pressure pill, but here's what can happen. You may start having ED. You may start having swelling in your ankle. I mean, all of this list. And they just don't usually do that. And that's my beef with most providers in general, whether it's surgical side or medical, not most, but a lot. Just be upfront with people. Be honest with people about everything, within reason that's possible so that people aren't freaking out. That's the thing. Just know what you're getting into. So
Ray says, I am currently on 160 milligrams a week, injections twice of cypionate, and adding Nandrolone for joint pain. How much should I adjust my tea with adding in Nandrolone?
I mean, it's impossible to tell on here because everybody's different. I would start by not changing anything other than adding Nandrolone. Like that's what I did when I started taking low dose Nandrolone for joint pain. I didn't touch my TRT dose at first because why would you change 2 variables at once instead of 1? So add the Nandrolone first to see how you tolerate it. Start low. I mean, seriously, 50 milligrams a week is usually plenty for joint pain relief. 50 to 80, something like that, 50 to 100. Wouldn't jump up to 200 milligrams a week of Nandrolone. I wouldn't even start at 100. It's got such a long half-life. Start at 50 milligrams a week for 6 weeks and then see how you feel. And if your joint pain gets better, but you still feel great, don't adjust your T dose. Like that's it. Just one variable at a time and be patient. I think that's the key with most of this stuff.
Mikey says, I do 140 milligrams per week. I have gained about 10 pounds since starting about a month ago. Do you think it's mostly water or muscle?
Definitely not muscle in a month. If you could gain 10 pounds of literal physical tissue in a month, that would be pretty amazing. No, we see this a lot. I had a guy not too long ago. He gained 20 pounds in like 3 months. He wasn't unhappy. I mean, he's doing better in the gym and, but I was like, it's mostly glycogen and water, but that's okay. I mean, it helps your performance. But you'll gain a few pounds of extra muscle in the first year, I would say, but don't expect 10 pounds of muscle, unless you're just starting fresh and have never lifted a weight and you're 150 pounds soaking wet and then you add testosterone. Okay. But even then it's not going to be muscle 10 pounds in a month. So
if you crashed your SHBG single digits before getting on TRT, but you don't want to get off TRT, how do you increase your SHBG fast?
You don't. That's not how it works. Because then you're artificially manipulating it. You're not letting the body do what it needs to do to get that SHBG back to where it wants to be or needs to be. If you've crashed it, then removing whatever crashed it and giving things time is the best thing to do. This desire, I see this all the time in groups and stuff. This SHBG topic has become so huge. Justin and I did a little interview and we talked about that. But this desire to artificially alter your markers, it's just it's misguided in the thinking part of it, because it's no different than artificially reducing your hematocrit by dumping blood. It's not a natural thing you're doing. So you're actually creating more issues by pushing the body in that direction quickly. Just like over dumping blood is going to actually stimulate erythropoiesis over time, because the body's overcompensating. People look at SHBG and they'll take boron to lower it, and they'll, increase their carbs to lower it, go on a keto diet to raise it. Yeah, that's fine. But if you're not going to stick with that long term, what's the point of doing that for the short term gain? Because it's just going to go back. If you crashed it, there's a reason it crashed. And so by removing that cause, you should be fine over time.
David Ridings, I don't understand the question. I guess you ask, is dividing the clicks of cream morning and evenings is still the best method? What do you recommend when starting out? Do all the clicks in the morning, in the evening, or half-half?
I start everybody on once a day in the morning, just to make sure I don't interfere with their sleep or anything like that. Once we get their blood work back to see how they respond to the cream, then I tell them if they want to play and do an evening dose, they can. If they feel fine doing morning only, stick with that. Don't overcomplicate it. It's 100% trial and error almost. And I think a lot of guys don't like those answers because they just want the answer, but there's not one answer. It's always, you got to find what works best for you. And like I said, I used to do twice a day on my cream. Now I do once a day and I feel fine. I don't have any issues with that. Some guys swear that they need twice a day. Well, then that's what they need. Like it really is that simple. So you have to be patient, try something, stick it out. Don't just like try it for a few days and go, oh, no, you really have to be patient to see how these things are going to play out. So with a cream adjustment, like I said, 3 to 4 weeks, I would say at least, unless you're just horrible. I mean, if you change something and like you're amped up, your heart's racing and you can't sleep and you feel terrible, like you're going to die. Okay. Like, don't do your cream the next day and get it, you know, and then drop it back. But that's rare. These changes are usually pretty subtle. So really just play with it and see what works best for you. The twice a day, some guys love it. Some guys think it's a hassle. So it just depends. Yeah.
What's your advice on flying with testosterone for injections? Pre-filled versus vials?
Let's see. Where is that on there? Hold up. They're asking about pre-filled syringes versus vials?
Yeah.
Yeah, I mean, I don't like the whole pre-filled syringe thing personally, but that's just a personal preference. Sorry, my camera is really grody right now. Vials are just going to be easier, and they're not going to hassle you, in my opinion. I've never had an issue flying with vials, as long as you take it in your carry-on, and you know, maybe have a copy of your prescription, or make sure the box has the actual official label on it or something like that. But most of these places in general aren't going to mess with you. I think pre-filled syringes would be more of a red flag because they're not going to know what's in them. I would definitely carry the official vial.
Yeah, sure.
All right, I'm gonna let me wipe this off. Hold up.
Yeah.
There we go.
Is hemoglobin 17 too high? My doctor halved my weekly dosage because of it.
No. Too high based on what, right? Who says what's too high? But no, my local hematologist, when I was in Paris doing urology, he didn't even blink, you know, because he got people sent to him all the time from other providers for secondary erythrocytosis. And we'd talk every now and then about it and joke. And he's like, he didn't even blink unless their hemoglobin was over 20 at all. And that's rare, honestly, for it to be. Mine ran about 18 when I was on injections. So no, this nonsense of just reducing your dose, like that's going to suddenly magically fix the hematocrit. It doesn't. It's still going to be higher than normal. Almost all these things are going to be outside of the normal range when you're taking testosterone. That's the other thing I'm kind of blown away that providers especially don't grasp. It's like they're okay with the testosterone. Some of them are okay with testosterone being higher than normal. But then anything else, no, we can't. Oh, your prolactin's 2 points above normal. Well, no kidding. You're taking testosterone exogenously. Oh, your estradiol's 60 or 80 or whatever. Yeah, you don't need to be testing it. But of course it's out of normal. Those normal ranges weren't made or validated with people taking hormones. Those were baseline levels. And that is just something that I don't know why that's so hard to grasp. We should all understand that. Providers especially should understand how lab ranges were formed and made. And then all bets are off once you're taking the exogenous substance.
Sure.
And this idea that there's this ideal or optimal number within that baseline range has no bearing on reality when you're taking a substance at all.
Mm.
So, yeah.
Then I'm back in the Facebook group. There was a question. In the Facebook group?
Oh.
What are the symptoms of high estrogen versus low estrogen in men on TRT?
Can't know it because you can't check and validate what aromatized estradiol is or isn't doing. You can't isolate that as an independent variable because it's attached to the testosterone you're taking. Serum levels don't reflect tissue levels. Like we've gone over this so many times. But you can Google high estrogen symptoms, but they have nothing to do with aromatized estradiol in men taking testosterone. Now, if you want to figure out what high E2 symptoms are, you could go take some estradiol and see how you feel, but that's not the same thing. That's taking a pill versus letting your body do what it's supposed to do when you take testosterone. Two totally separate topics that people often conflate all the time, and it's not the same. It's a category error, right? Aromatization is over here, taking estrogen is over there. Though they're not the same thing.
Yeah, so many people are still worrying about the high or even low estrogen symptoms. It's incredible.
I know.
There was a question about DHEA and pregnenolone over-the-counter supplements. They've already answered the best brands over-the-counter in the US. Are you recommending DHEA and pregnenolone in your guys?
It's more like, again, I'm very much about personal preference and goal, like right tool for the right job, that kind of like Broderick Chavez style thinking, right? But when it comes to this other stuff, I don't go off of serum levels with DHEA pregnenolone to tell somebody if they need it. If they're still like, let's say we get them on testosterone, they feel better, but still some things off. Depending on their symptoms, a lot of times we'll go for thyroid first just to see if it ticks those right boxes where they just feel good. Because in general, I think you're going to get more bang for your buck a lot of times with like desiccated thyroid than you are from DHEA or pregnenolone. But if they either don't want to go the thyroid route or they already have and they still feel like something's missing, it just depends on what it is. Because, you know, DHEA, I seem to see it a little more stimulatory, whereas pregnenolone a little more suppressive and in a good way, you know. So it depends on what their issues are. I see more negatives with DHEA than I do pregnenolone personally. I see more acne. I see more racing heart rate. I just weirdness, weird stuff. It almost feels like a dirty compound. It may just be in my mind. I've had a few guys we add pregnenolone and they resolve like maybe some penile sensitivity issues. Maybe they just needed to sleep better. Again, these things can tick a lot of boxes for various reasons that we don't even fully understand. So that's my answer to my patients is if you want to try it. Here's what I recommend as far as a brand. I'll give them a couple of, you know, good micronized, you know, forms and brands in the United States that they can order it themselves and then try it. And a lot of guys honestly come back and go, yeah, I tried it for a month, doc. I actually felt worse. So I stopped, and that's it. But some guys do feel better. So again, trial and error for me is the mainstay now. I don't go off of the big blood panels and all that like a lot of these places do. And that's just my own personal philosophy on this stuff.
Yeah. This question from John Thumb is you're the expert in answering this one. Do you recommend going to specific specialist urologist versus endocrinologist versus others?
Here's what I'll say to that is if you know this stuff and learn it, you will be able to tease through when you talk to somebody, you'll quickly figure out if they know what they're talking about or not when it comes to hormones. That's what I would say. That's the only reason I knew anything about this stuff is because I learned about hormones when I was 17, 18 years old for various reasons, obviously, but I actually loved the topic. And so I just devoured a bunch of this stuff. And so when it came time to go through med school and then finally residency, you know, and stuff, but you hear what people start talking about hormones and you know immediately that they're full of crap. And so I already kind of knew that. And so that's what I would say is watch the videos on the YouTube channel, go through the introductory, like the intro playlist that you've made, you know, educate yourself the best you can so that you are the best expert you can be. And not everybody can devour this stuff, but just do something to get the basics down. And then you're going to know real quick. And even if you go to an endocrinologist or an ex-urologist or whatever, that's fine to try. And then when they start going, okay, we're going to put you on 100 milligrams every 2 weeks and an aromatase inhibitor, you go, I'm not doing that. That's just what you say. You don't even go, oh, you don't bargain with them. You just go, no, we're not going to be a right fit. Now, unless you say, I want to do, you know, 60 milligrams twice a week to start, no AI, no this. And they go, okay, that's fine. Well, then maybe you found somebody that's at least reasonable. Mm-hmm. But in general, you're not going to find reasonable people when it comes to hormone replacement in the traditional medical community. It's usually going to be people that have probably already left that system or never went that traditional route to begin with. Not everybody. I mean, you're going to find diamonds in the rough, but again, that's all just random and lucky. There's no great database to search for. Help me find an insurance-based provider that knows what they're talking about and doing with hormones. There's no good way to search for that. So you may just get lucky, but in general, you're going to be better off probably going with a cash pay type place. But even then, it's a minefield when it comes to, because a lot of the big box clinics don't give a crap either, and they're just pushing product. And they're pushing aromatase inhibitors. So this is where, again, educate yourself so that when you go and talk to these places, you know pretty quick whether they actually care about this topic or not.
Yeah. Ali asks, how jacked do you plan on being at Silverback this year so Dave and I know what we're up against?
The jacked, yeah, not much at all, actually. I've let myself kind of go a little bit the last 7 months. We've eaten a little more than we should. So I'm hoping by the time Silverback comes, I'm back into my fighting weight, into my low 190s. But I don't call that jacked. I would just say not fat. But yeah, I wish I was jacked.
When you take testosterone, the aromatization to estrogen is neuroprotective. Is the ester or the preservatives neurotoxic? And does the extra estrogen counteract that too?
I don't know that there's any way to study that. I'll just be honest with you. The aromatization stuff, we're speculating, right? Because a lot of this stuff is done ex vivo, either taking away estradiol, like with an aromatase inhibitor, and then watching what happens and making reverse claims, or giving estradiol exogenously and seeing what happens and making claims. It's not the same as watching what aromatized estradiol does. You can't see that happen in the brain. You can't really study it directly. But whether these extra chemicals in the injectable are neurotoxic or not, man, I don't know. I don't have a clue. Again, this comes down to, is it worth the possibility that those are neurotoxic versus me actually feeling better and functioning better with testosterone? To me, that's a big, it's obvious testosterone causes way more positives than any like neurotoxic effects that we know of. I don't feel like my guys on injections are walking around feeling weird or having dementia. Now, again, brain fog, things like that. But does that mean neurotoxic? Not necessarily. You got to be careful with the words we use here. And again, this is trial and error. Comes back down to it. If you feel worse mentally, neurologically with injections, try cream. See if there's a difference. If there is, hey, you fixed your problem. We don't know what it was causing it, but you fixed it. So.
Is there ever the possibility of pulling the endocrine system into maintaining your endogenous test production while adding exogenous test, or is this just simply impossible?
Yeah, well, I don't know why you'd want to, honestly, because you're competing cross purposes there. Because there are clinics that try to push this, right? They'll say, here's your enclomiphene that you're going to take alongside your testosterone, or here's your aromatase inhibitor. So if they keep the estradiol low, then maybe we're going to trick the system into pumping out a little more natural. You're still fighting yourself, because you're now blocking, you're taking a poison essentially with those that's going to cause negative issues while you're trying to counteract them with the testosterone. It's like, you just take the testosterone. If you want to keep your natural production going for fertility reasons and stuff, it's a whole nother conversation. We've talked about the HCG and FSH protocols before. There's ways to maintain fertility while you're taking exogenous testosterone. I would not personally be taking something that's inhibiting estrogen or estrogen activity in the brain just to stimulate my testicles while I'm taking testosterone. I think you're asking to feel like crap, personally.
Okay, I guess we went through all the questions that were asked here.
All right.
So tell us, Jordan, can you still take on new patients? And if they want to, how can they contact you?
So right now it's a case-by-case basis. We got, it's just me and my wife, and she's seeing females. So for the male patients, it's just me. We're not hiring people. So once it got past about 800 on the list, I kind of stopped taking officially new patients, because I just can't. I can't keep up. So right now it's more people are reaching out if it's a referral, like a friend of a friend, or if somebody's like, I really need your help because I'm on this protocol and I'm fighting with this clinic and I'm feeling like crap. And so it's sort of like the guys that already know where I stand on stuff. It's going to be an easier transition. For guys that are just out of the blue, like, I just want to get my levels checked and see if I'm a candidate, I'm like, I can't just take on every person right now. But most guys are still reaching out, through the website at granthormone.com. I think our generic email is info@granthormone.com, and that comes straight to me. So just send me an email, and I'll be honest with you, up front, like, hey, I'm not taking right now. But what I'm probably doing is we're about to leave Monday to go on vacation, and that kind of smooth things out for about another month, and then maybe start taking more new patients on like late July and August, things like that. So
awesome.
Yep.
Okay, Jordan, I will let you go back to your weekends and do all the things you have to do.
That's right.
I want to thank all the viewers for the questions, and Jordan, talk to you next time.
Awesome, man. Have a good day.
All the best.